Welcome to This Medical Life podcast. These are the stories of medicine with Steve Davis and Dr. Travis Brown. This is the story of chronic kidney disease, part 1. I've just chased my little espresso with a big glass of water. Dr. Travis Brown, am I looking after my kidneys okay?
I believe you are. That's well. It's always interesting with fluid levels and how much people should be drinking. But yes, we are talking today about kidney health. And look, I would like to say thank you at the outset to Kidney Health Australia. They've helped us pull these two episodes together, two-part series, and they have some amazing resources on their website. One of the ones that we'll be referring to is a fantastic resource called Chronic Kidney Disease Management and Primary Care, freely available on their website, although you can purchase a hard copy if you want. And
we'll put the link to that in our show notes, won't we?
We will. And so, but this is, the first part is actually on screening, looking at patients and saying, let's try and find these patients early. Early intervention means better outcome for them. Second part of the series is actually patients who are at more risk with the two most common causes, one diabetes and the other hypertension. We'll dive a bit deeper into that with the second episode. So from a historical perspective, though, we've known about kidney disease. We didn't know what it was, but it actually was the term dropsy historically. So people who had dropsy came from the Greek term hydrops, which meant that they had excess water. And so this was looking at swelling and even Hippocrates noted these patients, and it noted the patients that had edema, so they had dropsy, also noted that they had cloudy urine. And so that will be a sort of a common theme because urine, you've got your kidney being damaged, losing protein.
It's interesting you mention this because I often think it being a modern disease with lots of salt in the diet, lots of alcohol, smoking. I didn't peg this one as one that has been with us for thousands of years.
And so you're thinking about lifestyle factors, yes, which are absolutely critical, but then they would have had those issues, but other kidney diseases throughout history. And so that's where we sort of noticed. Now, we wouldn't have known until modern times exactly the function of kidneys and stuff, but they knew that people that had these excess water, and even in the 13th century, the Italian physician Salicito, he looked at and described patients with dropsy. They had scant urines and contracted kidneys. And so they would have seen that, put the three things together, that these patients with excess water had problems with shrunken kidneys or, worse kidneys. And so the other part that they also noticed was this frothy urine. And so frothy urine, you'll actually, people can visually see. And so in folk medicine, so in the old times, they often thought this was a sign of evil, of internal damage. There's something that's happening. And so European folk medicine thought this was excess bile or excess yellow bile. And there was too much internal heat. And so they had cooling herbs. In India, they thought it was a vata imbalance. So this was an air or ether imbalance of going through. Traditional medicine, they thought there was excess dampness in the abdomen and lower tract, and so they would try and treat this dampness. And as I said, it wasn't until the early 19th century that our understanding of physiology and the significance of what frothy urine actually comes. And what it means is, or one of the main causes of frothy urine is you can have protein in your urine. And again, protein in urine our body actually wants to hold on to the protein as much as it can. This is something that we've developed. The kidney will filter out what it doesn't want, but protein out in our urine is actually showing that there is damage that's happening with the kidneys because you're letting out valuable resources. And so one of the things that sometimes I'm asked is, what's the difference between proteinuria and albuminuria? And the terms
I was going to ask you that.
And the term is often used interchangeably, but it's not really. One's talking specifically about albumin, but albumin's the main protein in our blood. So it's almost used interchangeably, but one of those things. But the most important person historically from this is Dr. Richard Bright. And now he's essentially considered the founding father of nephrology. Now, an extraordinary man, born to privilege, very well educated, wrote books, travelled, and studied medicine. Actually was Guy's Hospital in London. He was learnt, became a physician, became a teacher, and had keen observation skills and had an interest in clinical chemistry. Now, he studied kidney disease, and he looked at actually urine as a sort of detailed examination on urine specimens and found something critical.
One of the most ready means of detecting albumin is the application of heat by taking a small quantity of urine in a spoon and holding it over a candle.
And so what would happen is you would effectively evaporate the fluid portion, and then you would get this precipitate. And if the patient had lots of precipitate in it, then that was albumin or suggestion. Now, he did further experiments where he found out if you mix it with acetic acid, you can get phosphates, you can eliminate the phosphates, and that's got albumin. So, extrinsic factors going through. But you could actually see the protein. You seem quite concerned by this.
Oh no, I just was imagining a physician taking some of my urine in a spoon and holding it over a candle. I'm still stuck there. There's nothing great going on in my mind.
Right, and so yes, and that's the thing. So he actually studied what this meant, and he found that in 1820s, he studied the link between patients having swollen limbs, so this is edema, this frothy urine, proteinuria, or albuminuria, and this kidney damage, and found that they had kidney damage on autopsy. And so this became known as Bright's disease. Now, this is an umbrella term, effectively, of because they didn't have sort of glomerulonephritis those times, but this is pretty much suggested chronic nephritis. He even had a very good, his observations had an accurate description of what we say acute glomerulonephritis after a case of scarlet fever.
A child or an adult is affected with scarlatina or scarlet fever. He finds the secretion of his urine greatly increased, tinged with blood. He awakes in the morning with his face swollen or his ankles puffy. His urine contains a notable quantity of albumin. The urine is carefully tested. The quantity of urea is gradually diminishing. The swelling increases. The urine becomes scanty. He suddenly seized with a convulsive fit and becomes blind. Worn out by convulsions or overwhelmed by coma, the painful history of his disease is closed.
And so this is where we start to see kidney disease come in. So in the mid to late 19th century, we start to understand there can be urinary casts, there can be blood and hematuria, there can be protein that's seen under the microscope. By the 1930s and 50s, we actually start to be able to quantify the amount of protein or albumin in the urine. By the 1950s and 70s, we actually have proteinuria, which we can then break down into glomerular disease, diabetes, hypertension, the causes. And so we now find the late 20th century, you've got urinary dipsticks, we've got albumin creatinine ratio, and so we start to understand, we've pulled this all together, which is effectively quite amazing. When sort of someone says a blood test or a urine test, we can actually find out their kidney function, how everything, do they have kidney damage? And this is the important point, and it's a statistic that keeps on coming up in these discussions, that pretty much patients can have 90% of their kidney function almost all gone before they start showing symptoms. And so this is the thing about the critical nature of detecting the patients, because early intervention means that we can actually prevent them from getting to the worst stages or even need to be considered for transplant and dialysis. So we're going for early detection, quick and effective intervention, and then better outcomes for patients.
Maddie Williams is a registered nurse, Kidney Health Australia helpline consultant and renal transplant recipient. She's 28 years old from regional Victoria and at 17 was diagnosed with kidney disease due to vasculitis. Since then, she went from conservatively managing her remaining renal function to hemodialysis, to peritoneal dialysis, and then to transplant in 2018. She says she's incredibly lucky to have a wonderful working transplant from her dad. In the last few years, she's also returned to the renal department, but this time as a renal nurse and now working on the Health Inquiries helpline with Kidney Health Australia. Maddie's our guest on This Medical Life podcast. Maddie, welcome.
Thank you so much for having me.
Maddie, can you take us through that experience of being diagnosed with kidney disease?
Well, so I was only 17 at the time, so it was a very terrifying time for myself and for my family. So it was 2014. My symptoms were quite vague at the time. I was pale. I was very tired. I was actually having blood noses as well, and had been vomiting just periodically throughout about a 6-week period. I'd seen my GP a few times and we just didn't seem to be testing for kidney disease. It was the main thing that we found eventually. In year 11, I was busy, I was working, I had a part-time job, I was at school, but really I was sleeping every spare moment I had. At first, I was diagnosed with anxiety because it was during exam period time at school, and I was probably a little bit stressed, but I don't think stressed enough to cause these symptoms. So one day, after 6 weeks of going to see the doctor, Mum took me to ED. Well, actually, first thing in the morning, she gave me a banana smoothie and said, "I've had enough. I'm taking you to ED." And we got to ED. We actually did a pregnancy test first, which I knew I wasn't pregnant. I knew it wasn't that. They turned me away and said, "We're going to send you home. We haven't found anything." And my wonderful mum said, "We're not going home until we decide what's wrong." We did another blood test where we found my potassium was 9 and my creatinine was over 1,000. So at the time, I didn't know what that meant. And then very quickly, our wonderful renal doctor in Bendigo ran into the cubicle and said, "We're going up to ICU." Where I started renal replacement therapy, and it was a big journey from there. We had biopsies and things to try and work out what was going on, and later had a diagnosis of ANCA vasculitis, and this was with the granulomatosis with polyangiitis, which also is known as Wegener's granulomatosis. I ended up going to the Austin in Melbourne, where I had plasma exchange, rituximab, and was able to recover from this AKI with a renal function of about 40. So from there, that was where I went into conservatively managing my kidney disease, trying to look after what was left of my kidneys. But unfortunately, about 18 months later, got food poisoning actually and gastro, which knocked out what was left. So that is where I went to dialysis, went to hemodialysis, and then to peritoneal. And then very luckily in 2018 was very, very lucky to receive a transplant from my dad.
Wow. And that's most poignant given that we're recording this on the day after Father's Day.
I know. It's hard to top that gift.
Maddie, just one question, because I am not the doctor here, but the little bit that I have learned about kidney disease is it does tend to show up in older people. Yes. Do you think that is the reason why initially it was hard for those around you to think of this as a possible diagnosis?
Yeah, I think that's a huge part of it. Being a 17-year-old, I generally didn't have the risk factors. For many people, things like age, weight, whether you've got a past medical history or past family history, diabetes. There's all sorts of risk factors, but being a 17-year-old, I really didn't have any of those. I think looking back, I think a kidney health check is a relatively easy check to do. And I think that would have been really important to do early. We had many, many blood tests and many, many appointments, and I just yeah, looking back, I wish we checked the right things earlier. Kidney health checks really just involve the blood test, so that's checking the eGFR, a urine ACR, and getting a blood pressure check. So that's to help get you, so a relatively easy check that we do as health professionals quite a lot. But if we'd got onto that a little bit earlier, we may have noticed it. Yeah.
So you've actually gone straight into pretty much like most people with kidney disease, as Steve was mentioning, is older patients.
Yes.
So they almost sort of gradually increase to a point where they'll sort of understand. You've gone pretty much straight from being a sort of maybe a little bit, year 11, completely understandable levels of anxiety,
Yeah.
to exams, to going to ED and going to ICU, and then people telling you that your kidneys aren't working.
Yeah.
What is that like? I mean, because that's really quite. What did you think? What was your thoughts?
We didn't really know where to start. I think um, the priority of the health professionals around me was to get me safe and well. So we didn't really quite understand. I think we're able to look back now and get a better understanding of what was happening around us. But at the time, I think Dr. Google was our best resource. Um, and it was funny. I think my family very much went into this like knowledge is power kind of thing. Everyone was doing their own research. They wanted to know how to fix it, what we could do, and what it was going to be like. A really interesting part during that time was that I think we all thought that once we treat the issue, so that initial presentation in ICU, once we fix it, I'll go back to normal, which it really wasn't. Your kidneys don't just, there is some level of bouncing back possible after an AKI, but um, yeah, after going through all of that, there was going to be this new normal that I don't think we'd really prepared for.
Can you tell us about the experience of going on hemodialysis and peritoneal dialysis? Because that's very arduous.
Yeah, so before starting dialysis, um, I really grieved the loss of my kidneys. I think I grieved the loss of having a normal life, to be able to do what I like, go on a holiday, go do what I want to do during the day. And I'd just gone into working full time out of school at that time. So having to take that all away to focus on dialysis was really hard. Once I started dialysis, especially the hemodialysis is what I started on first. I felt horrible, and it was hard to manage the thought of that, was going to be my new normal. I felt so sick during that time. Luckily, going on to peritoneal dialysis, it gave me a bit more freedom. I found I was able to go back to working. I traveled a little bit more. But still, I don't think I realized how sick I was until I got the transplant. I think as soon as the transplant started working in my body, I felt like a new person. I had unlimited energy. Yeah, felt incredible. Yeah.
So, with your experience, how did you know and how did you learn about kidney disease then?
Lots of Dr. Google. I think a peer support as well was a really big part. I found that um, I'd go to dialysis and I'd be surrounded by a quite elderly population around me. And I wanted to ask the questions like, what would it look like in my future? Like, would I ever be able to have kids? Will I ever be able to work full time? They were the questions that I wanted to know. And that was not coming from the people within my dialysis unit. I actually found another young girl in my town who had started peritoneal dialysis and was on dialysis around the same time as me. So that was really valuable. I found that we were able to navigate that system really well, which peer support's huge. And it's something that people with kidney disease really seek out quite a lot. Yeah.
And I'm curious, what was the contrast between what Dr. Google said and what the, in quotes, proper professionals said?
Yeah, it was quite different. I think at the time, the resources available was generally from overseas. I found that we had a lot of resources from America and a lot of resources from the UK, and Australian resources were only very much like up and coming. It was only just starting to really be created with people like Kidney Health Australia. So I think I I think we saw the bad side a lot, which was really hard, is that we'd jump on a forum and see that people are really struggling, which absolutely is the reality as well. But I didn't get to see the potential of being able to have a full life on dialysis. So, yeah, very different. And I think sometimes the information from overseas shows a very different side. I think dialysis is very different in Australia compared to somewhere like America. We have very different protocols and things. So, yeah, very different information.
Now, you're working with the helpline, which we will come to in a moment, and your experience in being a renal nurse, I mean, you've certainly turned everything into, as your terrible experiences, you've turned it into a positive. But can I ask, you now, if you were to talk to your 17-year-old self, what advice would you give?
It's a tough one.
Yeah.
I think I would have advocated a bit more for myself. I think going to the GPs don't, they can't tell what's going on if you don't tell them what's wrong. And I think it's absolutely right for my doctor to assume that there was a level of anxiety during that time. But I wish I stood up for myself a little bit more to say something's not right. That would have been a big part for diagnosis. But I like, when I look back now, I ask all the silly questions when I'm at my doctor's appointments. I'm not a renal nurse when I go in to see the doctor. Back as being my 17-year-old self. And I have very good doctors that will respect that and, let me ask the silly questions. But yeah, and that's the thing. There is no silly questions. We say that all the time as nurses. There's no silly questions. And I think, yeah, advocating for yourself and asking those questions is very important.
Now you've got a transplant. How are you managing? How is that going? And you're taking a number of medications to stop rejection and everything. How are you going with all of that?
It's busy. Transplant's very much not a cure. It's a treatment. It's definitely easier than dialysis. I feel really well, and I've been very lucky to feel very healthy. But the medications absolutely do come with their own side effects. I have a lot of specialist appointments, lots of blood tests, lots of trips to the pharmacy and other allied health professionals as well. So it doesn't really stop. But I've been really lucky to navigate my work, which is really well, especially Kidney Health Australia has been really great, but to make sure that I have that time to keep up with my appointments and getting those tests to make sure everything's on track.
And you are working with the helpline with Kidney Health Australia. What are the common questions? First of all, probably, who's actually calling in and what questions do you commonly get?
Everyone's calling in. We're for everyone. Anyone that wants to navigate Kidney Health Australia resources or services, it's carers, families, patients, health professionals, anyone can call us. We get a really big variety of calls. One big one at the moment is Australia-wide is the financial pressures with kidney disease. We don't have a lot of options for Australians with kidney disease managing the financial burden of CKD. With the helpline, we're able to link our callers with some of those supports that are available, but that's a really big one. We also get lots of calls about holiday dialysis. We've got the big red kidney bus, but sometimes we've only got the 3 buses, so sometimes it's difficult to manage. If you want to travel to another state or another location, we can help provide some options for you and go through those. Diet and nutrition, that's a huge, huge part of our role on the phone. It's a big question that comes up quite a lot. It's a very complex diet, the kidney disease diet, and it can be so different for everyone. For those that have to avoid potassium, phosphate, salt, and fluid restrictions, it's very overwhelming. Unlike an allergy where you avoid one food group, you're avoiding potassium, which really all foods have some level of potassium. So we have, which I'll probably go into a bit later, but our Kidney Health for Life program we've just launched, which has been a really good resource for that. It's a brand new website and we have patient education information. It's health and lifestyle management, but it helps navigate the diet and nutrition side of kidney disease. We also, this is probably more for our GPs, but a conversation that I've had far too many times is I've been told by my GP I have my kidney functions reduced and I don't know anything about it. And I've been told I don't need to do anything about it, but I'm just not sure. And that seems to be the call, I think, for someone that may have had a slight reduction in their kidney function, there might relatively be not a lot that they need to do at the time. But I think there's so much, knowledge is power. And I think people feel overwhelmed in that time hearing something like that we help navigate resources and, a bit of reading that's appropriate for your level of kidney disease.
Just one very small question about the food advice. I know it's different for everybody. What are one or two food things that tend to be the safe ground for everybody? Is there such a
thing? Having a balanced diet is important for everyone. So that's going to be the main thing, making sure you are still getting, adequate protein, fiber, carbohydrates, just your nutrients overall. There is some vegetables and fruits that have high levels of potassiums and phosphates and things. Phosphate, for those, that's more for people on dialysis or in later stage of kidney disease, but phosphate is in things like dairy products, and a lot of processed food as well can cause problems with potassium and phosphates and additives, and especially salt. Salt is one we don't think of, that when your kidneys don't work, your blood pressure can go quite high. But if your blood pressure is high, it can also damage your kidney. So reducing your salt is one of those options to help manage that better.
Well, that's one of the direct outcomes that's come from doing interviews in this series. I've been reducing my salt intake.
Oh, so good work.
It's a good thing. Look, Maddie, just finally, do you have any advice or thoughts about chronic kidney disease for doctors and patients who might be listening in?
I think for doctors is just test for it. If there's risk factors, why not test for it? It is such a simple test. You go to the GP, you're often doing a blood test and a urine test. Why not add on that urine ACR if for someone that does have those risk factors? And it doesn't hurt, I guess, to get a baseline. If you know that someone does have those risk factors, understanding that, their kidneys may be fine now, but let's know where we're going to start from and what we can do to prevent it. I think patient education for doctors is really important, and whether that's from doctors in the appointment, there's generally not a lot of time to be able to provide thorough education, but being able to direct people to the right education, like our Kidney Health for Life program, which we've only just launched. I think, a knowledgeable patient can feel comfortable making appropriate health decisions as well. And I think for patients, the big thing is speaking up, because our doctors are busy. They are just people. They can't read your mind. So I think going into an appointment prepared, writing down a list of questions, I guess, and you get to take a bit more of responsibility on your own health, which I think is really important. And asking for help, huge thing. Yeah.
All right. On that note, Dr. Travis Brown, you make a note to link to that website in the show notes.
Absolutely.
All right.
Beautiful. Thank you.
Maddie Williams, thank you very much for being part of This Medical Life.
Yeah. Thank you so much.
Dr. Richard Pun is the Senior Medical Advisor at Westmead Hospital and has worked full-time as a nephrologist at Westmead and Blacktown Hospitals since 2007. Previous appointments have included Treasurer of the Australian and New Zealand Society of Nephrology, Chair of the Advanced Training Committee of Nephrology, and Director of the Kidney School Program. He's been a long-standing member of the Primary Care Education Advisory Committee for Kidney Health Australia and is a member of the Independent Hospital and Aged Care Pricing Authority Clinical Advisory Committee, and he's been elected counsellor for HCF since 2013. Currently, Dr. Pun is principal investigator on several international clinical trials with recent publications related to IgA nephropathy and various CARI clinical practice guidelines. And Richard's our guest on This Medical Life podcast. Welcome.
Thank you very much for having me on this podcast.
Richard, let's start with an important basic question. What are the symptoms of chronic kidney disease?
That's a great question. And I think the first answer should be that most patients actually don't have any symptoms of kidney disease. And for many patients, they can lose up to 90% of their kidney function before they get symptoms. So that's why we encourage screening and early detection of the disease before people get symptoms. But going back to what the symptoms are, they're slightly non-specific. So they're things like uh, lack of appetite, nausea, vomiting, sometimes itchiness, cramps, tiredness, weakness, shortness of breath, changes in the volume or appearance of the urine. So sometimes blood in the urine or frothy urine can sometimes be a symptom. And also swelling in the feet or ankles as well, sometimes because of accumulation of fluid. But as you can imagine, a lot of these symptoms sometimes can be a bit innocuous. Obviously, they're not all necessarily specific to kidney disease. And really underpinning all of it is what the first statement was, is that you could lose up to 90% of your kidney function before you develop symptoms. And if you wait for symptoms to develop, well, the horse is well and truly bolted. So we need to identify patients much earlier.
What is the best way to detect patients with kidney disease then?
Yeah, great question. I think there's a few parts to it. The first is that we really need to identify patients who are at increased risk of kidney disease first. And that includes patients, particularly with diabetes and high blood pressure, these being the two most common causes of chronic kidney disease, but also includes people who have established cardiovascular disease, a past history of heart attacks or strokes, those patients who are obese with a body mass index in excess of 30, patients with a family history of kidney failure, those patients who are smokers or vapors these days, patients who are over the age of 60, particularly First Nations Australians, they are at increased risk, and also people who have had any history of what we call acute kidney injury when they've had an acute decline in their kidney function. So the first step is actually to identify patients are at increased risk. And the way to do this are, there's a few different ways. GPs can identify patients using their practice management software. They can audit their patients and have a look at the patients who are at increased risk, looking at those parameters that I've just mentioned. Perhaps they could use questionnaires or surveys in the patient waiting rooms. And then patients can also self-identify as well. So if the patients take themselves to a 2-minute kidney risk assessment tool that's available on the Kidney Health Australia website, they can identify themselves as being as increased risk. And this tool can be used in all sorts of workplaces, can be used at home, can be used in a pharmacy, all sorts of different places. But there's an opportunity for patients to self-identify themselves or be identified by primary care practitioners as well. The next step is then targeted detection of chronic kidney disease in these patients. And this is where we talk about a kidney health check. The key components of which include a blood pressure measurement, measurement of a blood test looking at the creatinine level and EGFR, and also a urine test for the albumin to creatinine ratio, or ACR. And the reason we do all of these three things is because we know that in addition to the blood pressure, but as each of the other parameters worsen, the risk of progressive kidney decline, cardiovascular disease, the risk of symptoms, and the risk of death all increase significantly as these worsen.
So when we're looking at kidney function, you just mentioned those three tests. Is there any that you rely on more, like EGFR and creatinine, everything like that? Which is the best measure of kidney function?
The parameters each represent different things, but I guess if you take it in whole, each of them, as I said, as they worsen, they increase the risk of all of those things that I've already mentioned. The EGFR and creatinine, they relate to the kidney function, and the urine test for ACR relates to kidney damage. Both of those parameters are really important. And certainly, if you look at the CKD staging classification, both of those are taken into account. Certainly, if you do one in isolation, you're going to miss patients with chronic kidney disease. That's very well shown. If you go back to a study that was performed in around the year 2000 called the OSDIAB study, it found that about 60% of patients with protein in the urine didn't have an EGFR of less than 60, and about 90% of patients with an EGFR less than 60 didn't have protein in the urine. So if you measure one without the other, you're going to miss a lot of patients. Otherwise, if you look at studies looking at there's so-called the CKD Prognosis Consortium, it acknowledges the fact that both of those parameters lead to worsening risk of death and cardiovascular disease and the like as well. if anything, the urine albumin to creatinine ratio is a stronger predictor, but regardless, they're both really important. And I always tell people the analogy of crossing the road, that really, if you're going to do a kidney health check, you have to look both ways. You have to test for both EGFR and urine ACR as well. You don't want to get hit by that car.
Now, there was an amazing statistic. So 17% of patients, so almost 1 in 5, start dialysis within 90 days of being referred to a kidney service. And so I'm trying to work out, when's the best time for a patient to be referred to a kidney service or a specialist?
Yeah, the numbers are staggering, really, isn't it? I mean, for a first world country like Australia or New Zealand, you would expect that most patients are seen a lot earlier. That's what we call a late referral, when patients are referred to a nephrology service less than 3 months before they require dialysis or transplant. So obviously we need to capture patients a lot sooner. Certainly if you look at that end of the spectrum in terms of dialysis and transplant, we would like to see patients at least 2 years in advance, because even if they do end up requiring those therapies, we need time to educate the patient. They sometimes require surgery and other modifications beforehand, so that we're well prepared. And it's been shown that, as you can imagine, if patients are referred late, they do less well compared to patients who are referred earlier. So clearly, apart from the screening and early detection side of things, yes, sometimes patients do need to be referred to a nephrologist. That being said, most patients can be very well managed in primary care. But the key triggers for when patients should be referred are if patients have a persistent EGFR of less than 30, if they have persistent a urine ACR in excess of 30, if there's a rapid decline in EGFR, more than about 15 mils per minute per 1.73 meters squared over a 1 year period, or if there's a 25% or greater reduction in their EGFR over that 12-month period. Also, if they have resistant hypertension despite at least 3 antihypertensive agents, they also require a referral earlier. And then some patients may have complications that may require input of a nephrologist much earlier. And in particular, I guess that would include chronic kidney disease related anemia, when they might require commencement on therapy with erythropoietin. So those patients might require a referral to a nephrologist a little bit earlier as well. Finally, as I've already alluded to, there is a health inequity with regards to First Nations Australians, and recognizing that the prevalence of chronic kidney disease is twice as common compared to the non-Indigenous population, we suggest that these patients should be referred to a nephrologist even earlier. So when their EGFR is less than 45, or if their kidney function has declined by more than 10 mils per minute per year.
Classifications are often quite challenging sometimes for doctors and patients, because someone says you have chronic kidney disease, which actually is sort of a bit of a mental sort of shock sometimes. But at what level are patients considered to have chronic kidney disease?
Chronic kidney disease is defined as the presence for at least 3 months of kidney function or EGFR of less than 60, or that patients, regardless of the EGFR, if they have any evidence of kidney damage. So and that's particularly related to urine albumin to creatinine ratio, although it can relate also to patients who have radiologic or histopathologic abnormalities. So if they've had a kidney biopsy and it shows kidney disease, regardless of the EGFR being greater than 60, then they would be defined as having kidney disease as well. So the key elements in particular are the EGFR, the urine ACR, but in particular the chronicity side of things. So they have to have it for at least 3 months. You're right, it can be quite complicated and confronting talking about CKD staging. But essentially, as I've mentioned, there's the elements related to kidney function, looking at the EGFR, and kidney damage, looking at the urine ACR, acknowledging that each of those, as they worsen, they increase the risk of kidney decline, symptoms, complications, and overall mortality as well. And if you go to the Kidney Health Australia website, if you go to the CKD Management and Primary Care Handbook that's available on the website, or the CKD Go app, the CKD staging classification is provided there, and it basically provides a heat map type framework for the risk of all of those things that I've mentioned before, kidney decline and the like as well. And according to the heat map type framework, it also provides management recommendations and monitoring recommendations for those patients in the various stages of chronic kidney disease. So to go into it a little bit more, the kidney function looks at CKD stages 1 through to 5, depending on how severe the reduce the EGFR is. And then the kidney damage stage looks at the urine ACR and progresses from normal albuminuria, where the urine ACR is normal limits, compared to microalbuminuria between 3 to 30 milligrams per millimole, and then macroalbuminuria when it's greater than 30 milligrams per millimole. So what we talk about in terms of CKD diagnosis is kidney function, kidney damage, and then the underlying cause. So you would talk about a patient, you might say that the patient has stage 3 chronic kidney disease with macroalbuminuria secondary to diabetes and high blood pressure or hypertension.
Richard, I'm just inserting a footnote here. I know GPs will know the answer to this, but there could be patients who are listening to this episode. You mentioned kidney damage being measured, and there's one thing that springs to my mind. If it was the liver, I understand the liver's an amazing organ and good at regenerating itself. Are the kidneys not quite in that league?
Yes, I think that's probably fair to say. It doesn't have the same capacity as compared to liver disease. Certainly, as I think most of us online and yourselves, sorry to say, but we're all over 40. So from about the age of 40, there's a progressive decline in kidney function anyway. But that being said, we aim to slow the decline in kidney function related to age, but also related to all those factors that increase the risk of chronic kidney disease as well.
So when we look about or think about screening, who and how often should patients be screened?
The who part of being screened is the patients who are at increased risk that I've mentioned. How often, I guess it depends on whether they have defined kidney disease or not. If they don't have defined kidney disease, you look at patients with those who are in increased risk, and they should be screened every 1 to 2 years, depending on the parameter that you're looking at. But most patients probably at least every year. If patients already have chronic kidney disease, in terms of the monitoring side of things, it depends on what CKD staging classification they fall into. And so patients may be required to be monitored every 3, 6, or 12 months, depending on how severe their kidney disease is.
Now, you've mentioned it a few times, and it's a really important point about First Nations Australians. Why are they at such a high risk of chronic kidney disease?
Undoubtedly, it's a result of colonialization. There's an increased prevalence of all of those those factors that increase their risk as well, blood pressure and obesity and smoking and all of those sorts of things as well. But it's undoubtedly a result of colonialization. So that's the predominant reason.
Looking at it from a pathology point of view, is there a difference when you're looking at albuminuria? Is there a difference between sort of taking a spot urine albumin and a 24-hour collection?
I guess what you're alluding to is the fact that there are a number of different methods for detecting protein in the urine. And these can include urine dipsticks. And as you know, we have the normal urine dipsticks. We also have albusticks, but also spot urine collections and timed urine collections, often 24-hour urine collections. Of these, the most reliable, and recommended method for detecting protein in the urine associated with kidney disease is by performing a urine albumin to creatinine ratio, particularly using a first void morning urine sample. Albumin is a predominant protein in the urine. It's not all the protein, but it's a predominant protein. So if you're going to detect patients with kidney damage and protein in the urine, that's going to be the most sensitive method of doing it. More sensitive than a urine dipstick, and more convenient than a 24-hour urine collection. I don't know if anyone has done a 24-hour urine collection, but it's a pain doing it. And it's obviously not useful to do it on a regular basis in people carrying around urine bottles and the like as well. That being said, I guess urine dipsticks can still be useful because they provide information on top of the protein in the urine. So in particular, they can detect whether there's any blood in the urine as well. And the concomitant presence of both blood in the urine and protein in the urine can indicate that maybe there's a different cause of kidney disease. There might be what we call glomerulonephritis or a glomerular cause of kidney disease, and that may prompt a more urgent referral to a nephrologist, perhaps even for what we'd call a kidney biopsy.
On that note, I'm going to pause, take a big drink of water, and we'll regroup in a moment, Richard, and look at common causes and also lifestyle factors. We continue our discussion now with Dr. Richard Pun on chronic kidney disease. Richard, as I alluded to, what are the most common causes of chronic kidney disease?
Invariably, the most common causes of chronic kidney disease would be high blood pressure and also diabetes. But the other causes are the reasons for increased risk and the reasons for targeted detection. And that includes particularly patients who are obese, BMI over 30, age over 60, and the like as well. I won't go through the whole list again, but the most common causes are certainly diabetes and hypertension, but certainly obesity is catching up as well.
When you mention blood pressure, if blood pressure is being managed with medication, does that lead to a lower risk of chronic kidney disease?
Yeah, really good question. And I guess if you've got kidney disease, the recommended blood pressure based on evidence is different to patients who have blood pressure without kidney disease. So I have a myriad of patients who think that they have well-controlled blood pressure and it's actually not well controlled. So for patients with kidney disease, we recommend the blood pressure of under 130 over 80. That's different to the normal hypertensive population. I guess the other aspect of it is how you're measuring the blood pressure. And obviously we don't do blood pressure measurements 24/7. We can do 24-hour blood pressure monitors. But obviously when patients think that their blood pressure is well controlled, it may not be if they're not doing it at home, if it's only being measured in the clinic. So I encourage certainly all of my patients with kidney disease and with blood pressure to have a blood pressure monitor at home so that they monitor it and so that we really do know that their blood pressure is under control to that target of 130 over 80.
Now, you mentioned last segment about the stages of chronic disease, 1 to 5. Do they matter? Does that have a clinical significance to it?
That's talking about the kidney function side of things. And as patients progress through from stage 1 through to 5, if you look at the CKD staging classification, they go from green to yellow to orange to red, signifying that their risk of kidney function decline, the risk of requiring dialysis or transplant, the risk of symptoms and complications of kidney disease, the risk of cardiovascular disease, the risk of death all increases significantly. So it does have a very real implication for the patient. But again, it's really important to look at the urine albumin to creatinine ratio side of things too, because there's a very clear correlation that as urine protein increases, the risk of all of those things increases as well. And as I mentioned before, if anything, the association is even stronger with urine albumin to creatinine ratio compared to eGFR. So you really need to measure both.
So when should doctors start treating patients with chronic kidney disease?
So as early as possible. Really good question. I mean, obviously, the earlier we can detect patients, the earlier we can intervene, and the greater the opportunity for altering the trajectory of the patient's chronic kidney disease. The underpinning all of this, obviously, is if patients have chronic kidney disease, you treat the underlying cause. If they have diabetes and high blood pressure, you need to make sure that they have good glycemic control and blood pressure to that target of under 130 over 80. But now we have blood pressure tablets that have been well shown, particularly ACE inhibitors and angiotensin receptor blockers, to slow the decline of kidney function in particular and improve outcomes for patients with kidney disease. We also have more novel medications that are available these days. So SGLT2 inhibitors are indicated for patients, in particular, certainly from the initial indication for kidney disease with the eGFR between 25 to 75, with a urine albumin to creatinine ratio over 22.6 milligrams per millimole, which basically means that a lot of these patients are in primary care. And you can't just wait for referral to a nephrologist. In fact, they shouldn't be referred to a nephrologist. A lot of these patients should be just managed by primary care practitioners And many of these patients can be commenced on SGLT2 inhibitors according to those criteria. And that's not just for diabetic patients, that's also for non-diabetic patients as well. And now we also have non-steroidal mineralocorticoid receptor antagonists, finerenone in particular, that's available for patients with diabetes and kidney disease, already on SGLT2 inhibitors, with similar sorts of criteria. So urine ACR over 22.6 and EGFR over 25. Again, these patients should be commenced on treatment at the earliest possible opportunity if they do meet the criteria. There are PBS criteria for prescribing for these, but certainly the earlier you start with these treatments, the better for the patient, and potentially a number of patients won't ever need dialysis or transplantation.
In my reading, there was a lot of lifestyle changes and management. What were some of the goals for patients with CKD?
Yes, I think that lifestyle medications are crucial for all of these things. I've mentioned the most common causes of kidney disease, high blood pressure, diabetes. I've also talked about obesity. But clearly, if you intervene early with lifestyle modifications, you're treating all of these things. So really what we need is patients who have a healthy weight, a healthy diet. In general, for most patients, that would include the DASH type of diet, so low sodium, in particular, which impacts on their blood pressure management, high in fruit and vegetables, low in fat and saturated fat as well. Healthy weight, as I've mentioned, a healthy lipid type of diet as well. For some patients, that might mean cholesterol lowering tablets, particularly with statin therapy. And obviously for diabetic patients, they need to be on a healthy diabetic diet as well. And obviously the other lifestyle factors, moderation of alcohol intake. And if patients are smoking or vaping, obviously they should stop, because that certainly has been shown to increase their risk of progressive kidney decline as well.
Are you suggesting no alcohol or just moderate?
Just moderation of the alcohol intake. Certainly, there's good evidence that patients who drink too much alcohol will do badly. And I think it's a message that we should give to the general community anyway. You probably are aware that there are NHMRC guidelines with regards to alcohol intake, and patients should stick to that, if not a lot less. I guess the other issue for alcohol intake is particularly patients with advanced kidney disease. They may have problems with excessive fluid buildup in the body. So drinking too much alcohol, particularly large volumes of alcohol, can sometimes impact on their fluid status as well.
And so that moderated intake of alcohol, but when you said smoking and vaping, you were looking at abolishing that practice.
That's right. Nada. No smoking, no vaping. I don't advocate for either of those.
Now, we've mentioned that kidney damage, sort of the way to actually measure that is albuminuria. Is there treatment targets for albuminuria? Is there a sort of a way to be able to reduce that?
In general, our treatment target would be, from whatever you're starting at, that we hope to reduce it by at least half. And again, the medications that are available, RAS blockade with ACE inhibitors and angiotensin receptor blockers, SGLT2 inhibitors, non-steroidal mineralocorticoid receptor antagonists, they've been shown to reduce the degree of albuminuria by up to around that 50% mark too. But the earlier you get in, the better.
Now, you've mentioned medications to use. Is there medications to avoid for patients with CKD?
Medications in general require metabolism to be cleared by the body, either hepatic metabolism or renal clearance as well. So many patients with chronic kidney disease need to be wary of medications during the course of their chronic kidney disease. So for some medications, it means that they need to be dose reduced. And there's a whole list of medications that I could go through, but the common ones that I think about, obviously patients who have diabetes, metformin needs to be dose reduced, certainly when their EGFR is between 30 to 45. When the EGFR is less than 30, it should be stopped altogether because there's a significant risk of lactic acidosis. Also, benzodiazepines, they're not infrequently used in the community, so these may need to be dose reduced or avoided in patients as well. Some antiviral medications, some antibiotics need to be used with caution in patients. Not uncommonly, I see patients on trimethoprim, and that can lead to what we call pseudo-acute kidney injury, where the creatinine increases because the metabolism of trimethoprim is such that it competes with binding with clearance in the renal tubules and leads to an elevation of the serum creatinine when patients are on trimethoprim as well. Although sometimes it can cause acute kidney injury also. So those medications need to be used with caution as well. And then obviously pain medications, particularly the opiates, they may need to be reduced or not used at all in some patients as well. There are safer opiates that may be used, particularly hydromorphone, but certainly they all need to be reviewed with regard to these patients.
Wow, this has been a sweeping discussion, and I'm never going to walk down the street the same. I look around and there are going to be people with kidney disease walking among us, and the lack of symptoms means they don't know and we don't know. It's been quite a chilling discussion, actually. But in closing, Richard, any final advice or thoughts you have for doctors or healthcare professionals about chronic kidney disease?
I think, thank you for the opportunity to speak today. I think that it's really important to understand that kidney disease is a sleeping giant, really. And it's very common. It's definitely under-recognized by both the general community, but also by health practitioners as well. We also know that it's very harmful for all of those things that I've mentioned before. It's associated with about 11% of all deaths in Australia and 17% of all hospitalizations. And it's also very expensive. From a Commonwealth perspective, it costs about $10 billion per year. So we really need to have targeted screening of patients that are at increased risk. We need to look for opportunities to identify those patients that are at increased risk. And we need to be proactive in terms of the screening and the early intervention as well. And there are myriad opportunities now in which we can alter the trajectory of these patients and make their lives a lot better.
Dr. Richard Pun, thank you very much for being part of this medical life.
Thank you.
This Medical Life is recorded in the Talked About Marketing Studios in Adelaide. For show notes and more information about the podcast, visit thismedicallife.com.au. You can contact the hosts on social media. Dr. Travis Brown can be found on X. His username is @Dr. Travis Brown. That's Dr. Travis Brown. And Steve Davis can be found on LinkedIn. Go to linkedin.com/in/The Real Steve Davis. This has been a PathNotes Proprietary Limited production.